Welcome and thank you for joining us for this webinar on Use of Cannabis in Solid Organ Transplant Recipients, presented by the AST Transplant Pharmacy and Psychosocial and Ethics Community of Practice. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed on your screen. Please take a moment to answer this question while we finish the remaining announcements. The COP webinar is being recorded, and the recording will be available next week on the AST website and the COP hubs. Please note that all of your lines have been muted so that only the presenters and panelists can be heard for the archived recording. If you have any question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Please note that any questions submitted via the chat section may be missed during the presentation. And finally, at the conclusion of today's webinar, a short survey will appear on your screen. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators to begin our presentation.
Thank you very much for that introduction. My name is Margaret Jorgensen, and I'm here with my co-moderator, Alicia Chen, and our wonderful speakers today, Josh Wiegel, Scott Winder, and Lisa Tay. The objectives for the talk today are to describe cannabis pharmacology as it relates to solid organ transplant. We're going to summarize the available evidence on cannabis across the spectrum of therapeutic and recreational use and how this reflects on transplant outcomes. We're going to examine transplant center policies and the legal landscape of cannabis and appraise available evidence and controversies on use in transplant recipients to hopefully apply to your practice. As a disclosure, there is currently variation in designation of legality of cannabis. The U.S., the state laws, as well as those of the federal government vary on this issue, and the AST is not endorsing the use of any product. This presentation is meant to review the current evidence on the topic. So to address our first objective today on cannabis pharmacology, I will turn the presentation over to Josh Wiegel, who will introduce himself.
All right, thank you, May. Just a minute while I share my slides here. Okay, hopefully you can see my screen. Okay, so yeah, my name is Josh Wiegel. I am a clinical pharmacist here at the University of Wisconsin at UW Health. I got my PharmD degree from the University of Wisconsin and then did my PGY1 clinical practice residency out at Oregon Health and Science University in Portland. I stayed on there for 5 years after residency, working in their hepatitis C clinic and their abdominal transplant clinic, as well as on the inpatient abdominal transplant side. Moved here to Wisconsin in 2016, where I am currently practicing in both the inpatient and the ambulatory setting for abdominal transplant organs, with a primary focus on liver transplant. So I'll start off with a brief background of cannabis in medical practice. So the medical consumption of cannabis dates way back to 2700 BC, when Chinese documents acknowledged the benefits of cannabis sativa. It eventually migrated west to the Western world, and the US Pharmacopoeia classified it as a medical compound in 1851. Against the advice of the American Medical Association, cannabis was criminalized through the marijuana tax of 1937, and then eventually removed from US Pharmacopoeia in 1942. In 1964, the chemical structure of the main cannabinoid was identified in Israel, and it was named after the chemical structure, delta-9 tetrahydrocannabinol, or delta-9 THC. In 1970, the Controlled Substance Act and President Nixon's kind of declaration on the war on drugs led then to increases in federal drug control, punitive drug sentencing laws, and cannabis's classification as a Schedule I substance. So this was kind of another turning point, deeming cannabis to really have no accepted medical use and a high potential for abuse and unacceptable safety profile. But then things sort of changed a little bit in 1996 with the passage of the Compassionate Use Act, which allowed patients to possess and cultivate cannabis with a physician's prescription for the treatments of certain conditions such as cancer, AIDS, and chronic pain. And then more recently in 2012 was when we had legalization for recreational marijuana, first in Colorado and Washington. So not included on that timeline, but during the more recent years, it does date back a while actually though, to get some FDA approved products for cannabis in medical practice. So we had the first approval of dronabinol or Marinol back in 1985, originally as a Schedule II substance, but then it was changed to a Schedule III drug in 1999. Around that same time, the manufacturer of Nabilone or Sesamit was also seeking approval, but it was rejected then, finally got approval in 2005. However, this product is no longer available in the United States. So both the dronabinol and Nabilone are synthetic cannabinoids, whereas more recently we had Epidiolex, which was approved in 2018, which is a non-synthetic cannabinoid. So this does come from cannabis plants and the extract from cannabis plants. Epidiolex was initially a Schedule V drug, but actually as of 2024, it is no longer a controlled substance at all. FDA approved indications for these drugs include seizure disorders, chemo-induced nausea, vomiting, and AIDS-associated anorexia and weight loss. But of course, there are many other uses for these products, including PTSD, anxiety, cancer and non-cancer related chronic pain, muscle spasticity, and several other uses. So, there's many, got the pharmaceutical agents. Of course, there's many recreational products available in the United States and those states where it is legal, such as dried flower, which probably remains the most common form and is typically smoked or vaporized and is really high in THC, or the delta-9 tetrahydrocannabinol. There's other ones, pre-rolled joints, vape cartridges, which have oils that are used with a vaporizer and are highly potent, edibles, which effects generally take longer but also last longer, tinctures or oils, which are liquid and can often be used sublingually, concentrates, which are highly potent, and also topicals, which can be used to provide some localized topical relief. So there are over 100 different cannabinoids that have been identified within the cannabis plant, but there's really kind of two main cannabinoids that are used for therapeutic uses. So we have the delta-9 tetrahydrocannabinol, or THC, and we have cannabidiol, or CBD. So THC, or delta-9, is the major psychoactive component, and it naturally occurs in concentrations anywhere from less than 1% to 20%, depending on how the plant is grown and processed. CBD actually accounts for an even larger percentage of the plant, up to 40%, and notably lacks really any of the psychoactive effects due to some of the receptors that it works on in the body. It does not interact with any of the cannabinoid receptors. So a major downside of most of these products, aside from the pharmaceuticals, is that since they are Schedule I classification by the FDA, they are not regulated by the FDA. So you don't really know exactly what you're getting in terms of safety or efficacy. And even states where these products are legal, each state kind of has its own laws about testing the products for efficacy, potency, and any contamination with things such as pesticides. Again, making it more difficult to know with these products, that you're getting a consistent dosage and that you're getting something that is safe from potentially harmful chemicals. So there are two types of cannabinoid receptors, the CB1 and CB2. CB1 are found more throughout the CNS, on both neurons and glia throughout the brain, including the hippocampus, which is involved in memory function, basal ganglia and cerebellum, which are involved with motor function, and the cerebral cortex, which is involved with more overall subjective experience and executive function. The CB1 receptors can also be found outside of the CNS, on myocardium, vascular endothelium, adipose tissue, potentially the liver, and reproductive organs. That is compared to the cannabinoid type 2 receptors, or CB2, which are found primarily on immune cells. So again, may have some interesting effects with patients who have received a transplant and who are on immunosuppressive agents. So THC is a partial agonist at both of the cannabinoid receptors, whereas CBD appears to really not have any effects on either of the CBD receptors, but does have multiple other molecular targets throughout the body. So you don't get the same psychoactive effects with CBD as you do with THC. Interestingly, there are some data that show with long-term chronic THC use that you'll have downregulation of CNS CB1 receptors, and therefore you may have a less intense psychoactive response or effects over time with the same usage, and therefore may require higher doses to get the same effects. The synthetic cannabinoids, so our dronabinol and nabilone, are full agonists at the CB1 receptor, which may account for some of their effects being a little bit more broad and possibly more intense than using products from the plant. Absorption of the cannabinoids varies depending on the method of consumption. So inhaled products are going to be have much more rapid and much higher concentrations compared to oral administration. So with inhaled, you're going to get high concentrations within 5 to 10 minutes, and concentrations 3 to 35% higher than that with oral administration. With the edible products, oral absorption is much slower, 2 to 6 hours, and the bioavailability is quite variable depending on the product being consumed, as well as even just person to person. With oral consumption, one of the downsides of the delayed effects is in someone who is expecting a more immediate effect, may end up taking repeated oral doses, and then may inadvertently end up in kind of an overdosing situation. THC and CBD are metabolized in the liver by our cytochrome 3,450 or 450 enzymes. So THC with 3A4 and 2C9, whereas CBD is also a substrate of 3A4 as well as 2C19. In vitro data suggests that both may inhibit 3A4 and P-glycoprotein. So this does have some potential impact on our transplant patients who are on immunosuppressants such as calcineurin inhibitors, so tacrolimus or cyclosporin, as well as the mTOR inhibitors, so sirolimus and everolimus. So some of these pharmacologic considerations do raise some unique challenges for transplant patients, so including some immunology considerations, infection risk, especially with the inhaled products, psychological effects, potential drug interactions, among a few others listed here. So we do hope to address this throughout the presentation today. As far as drug interactions, unfortunately, the data in transplant patients is rather limited. There are really only a handful of case reports documenting known drug interactions between our calcineurin inhibitors and various cannabinoid products. I've got a table here highlighting the ones that I found out there in the literature. So the first one is a study that, or a case series of 25 patients on either everolimus or sirolimus using a CBD product. They did find that in 76% of the patients that their mTOR inhibitor levels were higher than they were before they started using the CBD products. The Hauser study looked at an interaction with a patient who admitted to using marijuana gummies about 14 days after their bone marrow transplant. They ended up with some tacrolimus levels much higher than expected, up to the mid-40s. The patient was also on an azole antifungal, posaconazole, and they did have some diarrhea that could have affected the tacrolimus levels, but the levels were much higher than the team expected, and it was thought to be due to the marijuana gummies. Unfortunately, there was little disclosed about the THC or CBD content of those. Another one by Modell et al. Looked at a patient who had been reporting to use 2 to 4 lozenges a day containing THC and CBD, and they found that those tacrolimus levels increased and ranged from 50 to 200% of their target goal. Again, thought to be primarily due to the patient's cannabis use. Another study by Lino et al. looked at a patient who was in a clinical trial for CBD with Epidiolex. They noted a 3-fold increase in the tacrolimus concentrations with associated AKI after the initiation of CBD. And they actually had required dose decrease of the CBD to help manage the interaction with the tacrolimus. The last case series here with tacrolimus and cyclosporin looked at a patient who was getting CBD products starting at 100 milligrams a day, progressing up to 300 a day. They found conflicting results. They actually saw that 2 patients had decreases in their tacrolimus levels, while 2 patients had increases, and 1 patient, their TAC levels remained stable. Interestingly, the 2 patients on cyclosporin had stable cyclosporin levels despite being initiated on CBD. The adverse drug reactions that were reported in these patients were somewhat broad, but for the most part were attributed to the use of CBD as well as potential toxicity from their calcineurin inhibitor. So my kind of takeaway from these is the data is quite limited. I think that with patients who we are identifying as using cannabis products, I think we need to have open communication to discuss what they are using, how often they are using, and being sure that we are monitoring the patient's calcineurin inhibitors very closely to monitor for any sort of interaction and changes in their tacrolimus or cyclosporin concentrations. I think that if you out there are seeing any issues, I think it is important to submit for case reports so we can add to the medical literature out there due to the lack of what's available right now, which really doesn't help kind of with this overall topic of are these safe for our transplant patients to use. I think we do need a lot more data out there, both in studies that do show some interactions and how those are managed, as well as ones if you have people who are using and there really is no effect on their calcineurin inhibitor. I think we just need more added to the medical literature around this whole thing. There have been several case reports in non-transplant patients looking at other medications that may be affected by cannabis use. So with anesthesia, it was actually noted in a case series that a significant portion of patients who had admitted to using cannabis actually required higher doses of propofol to I guess, maintain induction of anesthesia compared to non-users. Anticoagulation case series with patients on warfarin have shown a 20 to 30% decrease in warfarin dose requirements with patients using either CBD or THC. Anti-epileptics, there's been increased adverse drug events noted, specifically with valproate, things like elevated LFTs, thrombocytopenia, but also other studies show decreased valproate levels. So even despite the increased adverse drug events, the levels were lower. Increased levels of other anti-epileptics such as carbamazepine and the others shown there. Benzodiazepines, there was one case report that showed increased clobazam concentrations in a patient who was using CBD. And then caffeine. There was one study that showed higher concentrations of caffeine in patients who are daily CBD users. Anti-infectives, interestingly, rifampin, which we know affects the CYP3A4 enzyme, showed to decrease CBD and THC concentrations by 82 to 100%, whereas ketoconazole shown to increase the concentrations of THC and CBD. So again, very important for us to know what medications patients are taking with their cannabis to allow for management of these interactions. So just to briefly summarize, the use of cannabis in transplant patients is complicated. We do know that the different active cannabinoids do provide different therapeutic and adverse effects, and there are some drug interactions that do exist between cannabis products and the immunosuppressive agents. Communication is going to be key to identify that your patient is using cannabis. I do think that there needs to be probably an increased awareness and communication with our patients to figure out exactly how much they're using, as well as to be able to screen for and manage some of these potential drug interactions. One thing I didn't put on here is just the lack of data does make this a little bit more difficult in our transplant patients. And I do think that we all need to do a little bit better to try to publish some of our own experiences so that we can help add to the medical literature of how to manage these. So with that, I will hand it over to to Scott, and he is going to summarize the available evidence on cannabis use across the spectrum of therapeutic and recreational use and transplant outcomes.
Thanks, Josh. It's great to be with everybody today. I'm Scott Winder. I am currently at Henry Ford Health in the Transplant Institute, Department of Psychiatry, and finishing up my appointment process at Michigan State in the Departments of Psychiatry and Surgery. I was at University of Michigan for 9 years as faculty. I'm a fellow in the Academy of Consultation Liaison Psychiatry. I'm from Salt Lake City and got my medical degree at the University of Utah. So when we encounter cannabis use in the transplant center, this is really what we're looking at. Patterns of use that are sort of uncomplicated, all along a spectrum toward hazardous and maladaptive patterns of use that constitute what we would say is a cannabis use disorder. Cannabis use disorder in the United States is diagnosed using the DSM-5, internationally using the ICD. Just tends to denote an accumulation of consequences, as well as loss of control, social impairment, physiologic dependency, cravings, urges, withdrawal. So it's a list of criteria and kind of a tally to kind of indicate and denote severity. I think if we kind of maybe put on a more nuanced and sophisticated hat, this is really what we're up against in the transplant center. We're going to interact with patients who are using recreationally just because they like how it makes them feel and there's really no complications. There are some who are using it for medical reasons under the auspices of a clinician of some kind, or either treating a symptom, quote unquote, medically, again, a spectrum under their own direction. Then, even outside of a cannabis use disorder, there will be patients who are using, but the main manifestation is simply a psychological dependency where they've come to rely on it for psychological, emotional reasons, or a physical dependency where they stop and they experience a withdrawal and they resolve the withdrawal by going back to use, and then cannabis use disorder. So I think it would behoove all of us to be able to think about use, obviously on a spectrum, but according to these types of categories. And Dr. Chris, a transplant hepatologist at Colorado, and a group of us put together kind of an article cited here on this screen, which included kind of an algorithm, which I won't read to you, obvious, but kind of at the equator here are some key elements that kind of guide us to understanding why patients use and to kind of make a determination if this is something that's of concern for candidacy and or clinical outcomes. And those include things like, how is the patient when we discuss it? When we bring up kind of the nuances, some of the elements that Dr. Wiegel talked about, how do patients respond? One of the manifestations sometimes of bad habits, regardless of what type of habit we're talking about, it triggers emotional reactions and defensiveness and concealment and deception and a constellation of emotional responses that doesn't mean there's a problem, but it can be a marker of something that might require some delicate and respectful exploration. We want to understand also if patients have been using other substances, either prescribed or not, and the effects of that, if they have a psychiatric history, if they're using large amounts of cannabis. Dr. Wiegel talked about some of these formulations, particularly things like dab and wax, these products that are heavily concentrated, THC concentrations in the 80 and 90%. So there's really no medical reason for this, and is a level of use that is far outside of the statistical norm. So we would want to know that. And then why are they using it, and ways in which we can investigate that, talking to other clinicians. And I'll say more about that before I finish up here. So if we pivot to transplant itself, again, there's a theme that Dr. Wiegel mentioned, and that is that there's not a lot of data, but there are some. And let's review them briefly. So Stark et al. Looked at kidney candidates, about 3% with a cannabis use disorder. This was published in 2019. Jan and Foreman, 2021. This is, to my knowledge, the largest and most detailed look at the type of cannabis use in terms of indication and formulation, because they investigated CBD use. And you can see how common it is for current and former use. Again, these are recipients. And again, current and former use for CBD, mostly for things like just feeling good recreationally, anxiety and pain, as well as some indications for nausea. So what does it do? How does it affect things? These are data from my previous institution, the University of Michigan, published in the American Journal of Transplantation in 2009, which basically showed there is no effect when looking at survival. Cannabis users tended to be younger and male, more likely to have hepatitis C, lower MELD, and other prescribed and recreational substances, but didn't affect survival at all. These are kidney data, 1,200 kidney transplants over 5 years, and only one of these patients who was known to use daily, which I think severely impacts how much we can say. But the biomedical data are reassuring, that I flagged there in green at the bottom in terms of survival and graft failure, graft function. In red there, you see a theme that I'd like you to take from this, and that is the higher levels of substance use and just general concern from social work that these patients are higher risk and a higher level of addiction treatment. I think these are North Carolina data, and these were published in 2019, liver recipients. The snapshot here is that cannabis didn't have any effect on post-transplant survival, contrasted with tobacco, which you can see there had 3 times the 5-year mortality compared to patients who had never used. And there's a note in this article that even though these data were more reassuring, the team was still not allowing cannabis at the time of publication. That may have evolved. So again, just speaking to kind of how we feel about cannabis, and I think Dr. Tay will talk about that. The policies are kind of all over the place, and that creates some of the challenges when we encounter these patterns of use in our patients. And thankfully, there are newer data. These are kidney candidate data, 12% of them using cannabis, which delayed or reduced their likelihood of being cleared psychosocially for transplant, though once they got cleared, cannabis didn't have any impact on whether they got transplanted or not. And then when they looked at a sample of recipients, there was a higher risk of biopsy-proven acute rejection and death-censored graft failure. To my knowledge, these are the first emerging data that there is a biomedical problem in some of these cases of cannabis use. I mean, to be fair, there wasn't an impact on total graft failure or death with graft function or 1-year readmission rates. But I will flag here from the same article that you can see with historical use and current use the level of non-adherence and history of mental health conditions. And again, that's that theme of some of the psychosocial risk factors that travel with patients, many of whom, who use cannabis. And studies like this don't report a lot of psychiatric data. So in fairness to these patients, there could be confounding psychiatric variables that can account for some of these problems, even the biomedical problems that we don't yet understand. So I think it's premature to just say that cannabis is doing this. And then this is the last article I'll kind of dissect for you here. This is in production. These are brand new data for the perioperative, postoperative course of liver recipients, 4,000 of them. And the main finding here that you see in the graph is that there was a statistically higher opioid oral morphine equivalent usage or requirement in patients who had a positive urinary immunoassay significant for cannabis within 90 days of their liver transplant evaluation. That was the exposure. But all those other risk factors there or outcomes, this was not a significant factor. Again, there's not a lot of psychiatric data, and sometimes it's unfair. Many of these are biomedical teams and authors who are writing these articles and reporting these data. So it's kind of unfair sometimes to ask them to do a thorough psychiatric assessment of these patients. But at the same time, without these data, it's hard to understand this on a deeper level. So we provided some guidance, we hope, that's helpful in this regard. And this was a bunch of transplant psychiatrists and psychologists. What we came up with as we reviewed the literature and just kind of an informal consensus is that there's insufficient evidence for cannabinoids as a psychiatric or addiction treatment. The American Psychiatric Association says as much. We should be prohibiting this in our candidates if we think that it will cause or worsen psychiatric or addiction problems, and we should continue to monitor it. When clinical factors allow, again, the risk-benefit and the assessment of the entirety of the case, we should be postponing transplantation surgery until a cannabis use disorder, a cannabis addiction, is in remission. If there's a question about a patient's medical use, we should be referring to medical specialists. I like to think I'm a well-rounded physician. I cannot comment on the appropriate use of a cannabinoid for neuropathic pain or for migraines. And so my neurology colleagues would need to weigh in. Just based on legality, that's not enough to talk about appropriateness. I think Dr. Tay will talk about some of the data that legality actually, unfortunately, is like a major factor that we're using to allocate organs. If there are clinician colleagues who are stigmatized, who are judging and moralizing about this, or who love the idea of legalized cannabis and just think it's fine and everybody should use it and there's no big deal, it's natural or what have you, I think we need to be careful about these more extreme views. And then interprofessionalism and communication is a takeaway we want to emphasize. I'm over time, so I won't read this to you. And then I will hand things off to Dr. Tay, who will look at the policies and the legal landscape of cannabis use. Thank you.
Thank you so much, Dr. Winder. Wonderful presentation. Sorry, I'm trying to, okay, here we are. All right, so my name is Lisa Tay. I received my PhD in clinical psychology from the University of Hawaii, and I did a fellowship in transplant psychology from Indiana University. I'm currently the director of psychology and transplant psychiatry at Montefiore Medical Center, and I'm an assistant professor of psychiatry and behavioral science at the Albert Einstein School of Medicine. All right, so I'm going to talk about the current policies and legal landscape of cannabis in the United States. So over the last decade, various groups of transplant professionals have published calls for action to develop clear and consistent guidelines for cannabis use in recipient selection. And yet to date, there are no such guidelines available. Over the year, as more and more data on the pharmacological and other medical risk concerns related to cannabis have become more and more clear, there has been a shift from the focus on the legal status of cannabis use to these medical risks. However, the legal status does still play a role in our decision making, and policies vary widely across centers, which does in part have to do with the legal policies that have impacted our decision-making process in both clinical and research practices. So in 2023, the Psychosocial and Ethics COP held a Controversies in Transplant conference on cannabis use. Prior to this conference taking place, members of the Psychosocial and Ethics, Transplant Pharmacy, and Infectious Disease COPs were surveyed on their center policies regarding cannabis use and recipient selection, attitudes about cannabis use, and their priorities when making decisions based on cannabis use and transplant. We found that most members of centers surveyed were unaware of their center's policies and/or they did not have clear policies related to cannabis use, which was a finding that was reflected in prior research from Milarango et al. The legal status of cannabis use in general varies widely across the country, with 4 states considering cannabis both medically and recreationally illegal, and 25 states now considering cannabis use to be legal recreationally. This variation is a moving target, with more and more states having legalized cannabis recreationally in recent years. While the legal status of cannabis use at the state level does not necessarily need to have an impact on transplant decision making regarding listing, it often does have a considerable impact on patient and provider attitudes towards cannabis use, which can in turn impact both creation and enforcement of policies in transplant. When cannabis was legalized recreationally in New York, I expected to see an influx of patients using cannabis. I did not. I did, however, see an influx of patients reporting the cannabis use they had already been using for decades. And at the same time, there was also an influx of providers who had changed their positions on cannabis use to become more and more permissive, even as evidence was mounting about possible concerns related to cannabis use. Now, further complicating the legal environment for cannabis use in solid organ transplantation, there are 13 states that currently restrict committees' ability to decline patients for cannabis use alone. The exact specifications of these restrictions vary by state, leading to built-in inconsistencies in the way we can address cannabis use and selection across state lines. For example, a patient in Connecticut cannot be declined for positive cannabis metabolites in their bodily fluids, while protections in California are restricted to medical cannabis use. As such, the same individual may be declined for transplant in one state, while a transplant center may be restricted legally from declining them for cannabis use in another state. Although medicinal cannabis use is legal in most states and recreational cannabis use is legal in much of the country, cannabis remains a Schedule I drug federally regulated by the Controlled Substances Act of 1970. This indicates it is considered to have no accepted medical uses and also a high potential for abuse. Classifying cannabis use as a Schedule I drug has significant implications on our ability to conduct appropriate research on cannabis use and transplantation, as the ability to conduct research on Scheduled I drugs is highly regulated, and it is not possible to receive federal funding for such studies. A part of the regulation related to Schedule I drugs is that the cannabis used in research must be obtained from specific government approved growers, and this may lead to some difficulties with the generalizability to the cannabis our patients are actually using. So a lot of these research restrictions are really the reasons why we do not have the quality or quantity of data available to us related to the risks related to cannabis use. So due to these limitations, it's extremely challenging to do prospective controlled trials of patients using cannabis, and this may limit our ability to make empirical conclusions and communicate these to patients. So there's some very important questions that we cannot answer for patients because of restrictions to our ability to research cannabis use. These include what is actually in the cannabis that our patients are using. Are different formulations of cannabis safer than other formulations in our transplant patients? What type of infectious agents are found in cannabis that is on the street that our patients have access to, and also even in medical cannabis? These are all questions that we cannot answer due to research restrictions. So in summary, opinions on the safety and utility of cannabis use post-transplant varies widely, and many transplant centers do not have concrete policies regarding cannabis use pre and post-transplant. The legal status of cannabis use varies by state, and there are a growing number of states with legalization or legislation restricting the number or transplant decisions. The current legal status of cannabis federally creates roadblocks for collecting prospective and controlled data regarding cannabis use, and all of this variation can contribute to confusion and disparities in organ access within and between centers. All right, I'll now hand it over to the moderators for questions and answers.
Thank you, Dr. Tay. Let me just get the slides. All right, so to address the fourth objective, I'm just going to summarize this excellent information reviewed by the speakers today, so we can, sort of see how we would apply this to our current practice. So as far as best practices and recommendations, as we learned from Dr. Wiegel, Dr. Winder, and Dr. Tay, there's insufficient evidence to support the use of cannabinoids, certainly for therapeutic treatments for psychiatric or substance use disorders. So, that goes without saying. If a patient has a diagnosis that requires, some sort of medical response, they should be referred to the correct and appropriate care provider for that. And then jurisdictional legality is not really a sufficient standalone factor to determine appropriateness. And when you're talking about legal drugs, alcohol and tobacco certainly are a good example of how problematic using legality alone can be. Suitability should really be approached on a case-by-case basis and attendant on other clinical factors of the patient. And then we should all be aware of either our own stigma or advocacy even towards cannabinoid use and address these biases, because bias is really what disrupts the advocacy stewardship equilibrium. And sometimes our own bias can become somewhat emotionally charged, like Dr. Winder called out, and it can be challenging because of this emotional charge subject to be aware of our own biases about the topic. Future studies utilizing more softer psychosocial endpoints are needed. So we do have some studies looking at graft and patient survival, which are important, but there might be a confounder at play here, or a dark horse in the background where the cannabinoid is really a marker for some other psychiatric disorder or substance use disorders or issues with other psychosocial factors. Also, we need to look at quality of life and impact on medication adherence, as well as, when you're talking about liver transplant, regain sobriety or return to other substance use. And then these will need to be weighed against the classic parameters, such as the graft and patient survival. And then if we get some sort of framework for how to analyze this, it can be applied to other psychosocial topics that are analogous and maybe highly emotionally charged. So in conclusion, communication is key. And also we need to have consistent decision-making and messaging within our teams and across centers to avoid any access disparities like Dr. Tay had described. We now welcome your questions to the presenters. And Alicia, did you see any in the chat? I think I saw some come through.
It does look like some came through and they were answered through the chat. I was curious. We reviewed listing criteria regarding cannabis and how it varies across centers. And certainly, as clinicians, we have our own implicit biases. So, with that, I was curious on what considerations we should take into account when creating listing criteria to ensure equity to transplant.
That's a really great question, Alicia. So I think some of the important factors are making sure that the entire team is on the same page, first and foremost, because if patients are hearing from one provider that cannabis use is allowable at the center, and then they're hearing from other providers that it is not, they're probably going to listen to the person that said it was okay. And also making sure that the team is on the same page with regards to the risks. Now, definitely, whether or not there are any particular legal restrictions on listing declinations or whatnot in your state is important. And I also think it's also important to know what the parameters are around that, and also around neighboring states too, because we do share organs within the circles of acuity that are beyond our own states. So if you are having an overly restrictive kind of listing criteria in your center, then the neighboring state, then you may actually kind of be limiting your own patients' access to organs regionally, which can be a challenge.
Thank you very much for that answer. Any other questions in the chat? Don't be shy.
We also talked about the potential risks of cannabis with our patients and making that clear to them in the listing phase. How can we better approach that conversation with our patients, not only in the listing phase, but also post-transplant as that comes up later on?
I guess I could take that. So this is, I think for a lot of the psychosocial folks here, I mean, motivational interviewing, meat and potatoes or breathing air, we have been accustomed to using it. It's a communication paradigm that by definition is neutral. It kind of strips the interviewer. We strip ourselves down in terms of judgment or assumptions, and it's very patient-centered. It does a lot of things. I can't summarize it adequately in a few seconds, but one of the things that the reason I bring it up is because it allows clinicians to approach sensitive topics neutrally, less likely to trip these tripwires that set people off and convince them that we're just gatekeepers and we don't care and we're just looking for a reason not to give them a kidney or a heart or a lung. And the other thing that motivational interviewing does is it elicits patients' own understanding and their own motivation, maybe to look at something a little bit differently, and it asks permission. We actually ask permission to share some new information. It's a partnership. It's this amazing thing. It's one of the most satisfying things I do as a physician is to use this type of communication, to sometimes do what nobody else really can, either because my colleagues are too busy in clinic or the health system, as wonderful as it is, just is really clumsy sometimes with these delicate psychosocial issues. So if there was one place that I would refer clinicians to, it'd be to the 4th edition of the motivational interviewing book, or to a motivational interviewing kind of mentorship or workshop in your institution, because this is a way that we can speak to patients about the data that we do have, acknowledge what we don't know, express compassion that we don't want bad things to happen to them, either fluctuating serum immunosuppressant levels, or problems with anxiety or panic, or recurrence of new or old substance use disorder symptoms. There's a there's a real art to communication that is wonderful as transplant medicine is. It gets so technical and hyper specialized and biomedical that like really basic stuff about not making patients angry and not being judgmental and not putting them on the defensive just vaporizes. And we think we're good at it, and we may really not be. One of the best things that I ever did in psychiatric residency was I interviewed somebody behind one-way glass in front of all my colleagues. And I thought I was a pretty good interviewer until I had other people watch me. And I've never forgotten that sometimes we think we're talking about things in a way that's helpful and empathic and benevolent and kind, and we're really not. We're wearing a facial expression that shows disgust or impatience. And so I put myself first. I've made so many mistakes, still do. But I think if we're going to talk to patients about cannabis use in the pressure cooker of organ transplantation, we should be really sure that we've got some semblance of understanding of these data and some ability to communicate in a neutral and compassionate way.
Here, here. All right. Well, if there are no further questions, thank you all for your attendance. A lot of questions that still need to be answered, and hopefully ongoing changes to the legal status will allow future research that can provide more information about both soft and the more classic outcome measurements.
We would like to thank our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey, and the recording of the session will be available next week. Thank you again.